Good afternoon, everyone. Welcome back. Thank you for coming back and joining us. It gives me great pleasure to finally introduce to you Dr. Babak Mokhlesi, who is our keynote speaker this afternoon. Dr. Mokhlesi is a professor of medicine at the University of Chicago and has been there for the last 15 years. He is the Sleep Fellowship Program Director in the Department of Pulmonary Critical Care and Sleep Medicine at the University of Chicago. Dr. Mokhlesi's academic accomplishments are many, of which some of the highlights I shall share with you is he is an associate editor on thorax. He is the associate editor for the Journal of Clinical Sleep Medicine. He is on the editorial board of CHEST. He is involved as a lead investigator for a clinical trial on suvorexant right now in chronic insomnia. Regarding Dr. Mokhlesi's work, I'm sure many of you have read articles written by him on obesity hypoventilation syndrome and on OSA related to metabolic factors, diabetes, hypertension. I can just say to you that I have found him to be one of our leading clinicians in the United States as an expert in OHS, and that was why he was chosen probably as the lead author for the 2019 guideline from the American Thoracic Society. So without further ado, please join me in welcoming Dr. Mokhlesi. Thank you.
Thank you, Dr. Brown, for the kind introduction. It's a pleasure to be with you all. Hopefully in the future we can do this in person as well, hoping for getting back to normalcy. I'm going to talk to you about what we've learned in the last few years on doing research on obesity hypoventilation syndrome. And before we start, I don't have any conflict of interest to disclose. Part of that is because for those of you who may be involved in, putting together ATS clinical practice guidelines, one of the requirements is not to have conflicts of interest, believe it or not. And the idea that they push for is not to have conflict of interest up to 2 years after the guidelines are published. So I'm hoping to get more conflicts of interest down the road. So the objectives that I want to cover with you, as you can see on the slide here, is kind of set the stage in terms of definition, epidemiology, and diagnosis of OHS, touch base on the ATS guidelines, and discuss some of the advocacy work we're doing in terms of trying to make life easier for clinicians and patients when it comes to prescribing treatment devices for these patients. And I always like to start with an example of how these patients look. For those of you who practice sleep medicine, this is a familiar slide for you. This is a hypnogram with the sleep stages on top. You can see severe hypoxemia, not only continuous hypoxemia, but also intermittent hypoxemia with the sawtooth pattern. You can see the transcutaneous CO2 levels and a lot of apneas marked here. Each tick mark is an apnea. So you might say, well, why would you torture this person and not do a split night polysomnogram? Well, because this was a research study. And you can see I marked for you in terms of giving you a sense of the extent of hypoxemia that these patients experience, patients with OHS, is typically much more than your garden variety severe OSA. And here's your transcutaneous CO2 levels, just to give you a sense of where we are. The darker blue line is 55 millimeters of mercury. Again, you can see in REM sleep, there's more CO2 retention and there's even more hypoxemia. So most patients with OHS also have severe OSA, as you can see in this scenario. In this particular patient, the AHI is 96 almost, you can see in this corner. And here's the example I was showing you. You can see these prolonged, in this situation, this most common phenotype of OHS, which is accompanied by obstructive sleep apnea. You can see there's severe apneas, mixed or obstructive apneas with significant hypoxemia. You can see these desaturations going almost by 20 or 30 point drop in oxygen saturation. So pretty severe intermittent and to some extent persistent hypoxemia. So again, the definition obesity part of it is a no-brainer. You know, you need to have BMI that's elevated. Mind you, in Asian countries, the definition of obesity could be BMI of 27 or higher. Suffice it to say, the more obese the patients are, the higher chance they have of developing obesity hypoventilation. For example, in people of European ancestry, it's very uncommon to see obesity hypoventilation syndrome with BMIs below, you know, certainly below 35, but even below 40. As opposed to if you look at cohorts from Japan or China or South Korea, and you can see that with BMIs of 35, 36, the prevalence of OHS could be similar to BMIs, cohorts of people of European ancestry with BMIs that might be in the mid-40s. Hypoventilation defined during daytime as CO2 above 45 millimeters of mercury, particularly if you're at sea level. Again, the great majority of these patients have OSA. 70% of these patients have severe OSA, meaning AHI above 30. But there is a small cohort that doesn't have OSA, and they just have hypoventilation during the daytime that just gets worse during sleep. And again, not to be dogmatic about ruling out other causes of hypercapnia, but you know, because the reason I say that is because many of these patients, due to their severe obesity, may have some mild degree of obstructive airways disease or some degree of thoracic restrictive defect because of, heavy amount of weight under exerting pressures on their chest wall. But nonetheless, the point here is that you don't want to label them as OHS if they have severe COPD or very significant parenchymal lung disease and whatnot. So at the end of the day, it is a diagnosis of exclusion with the caveat that I just mentioned. So what I want to illustrate on this slide is how obesity, and if I could include another series of bars here for 2020, it would show that overall obesity defined as BMI above 30, which is the orange color, has plateaued in the recent years based on the CDC reports that get published in JAMA once in a while. But with that said, once you're in the obese category, there is no limit. You can continue getting more obese. And that's what I think this slide is illustrating, that even though obesity is not increasing at that rapid of a pace, morbid obesity, or severe obesity defined with BMIs above 40s or 50s is really increasing much faster rate. And in fact, recently in the JAMA, they reported that these increases have been more significant, particularly in BMIs above 40 and 50. Now, we don't know what the prevalence of OHS is in the community, but several studies have looked at what's the prevalence in obese people referred to sleep disorder centers for evaluation of obstructive sleep apnea. So within that group of obese with suspicion of OSA, you can see there's a lot of numbers here, but I'll just call your attention to this red box here. The composite of these is around 17%. So anywhere between 10 to 20% of patients who are obese and referred to the sleep programs probably have a component of hypoventilation. And to no surprise, as the severity of obesity goes up, the prevalence of OHS goes up, as you can see here, regardless of whether the studies are done in the UK, US, France, or Italy. So this is kind of like a back of the envelope calculation of what could be the prevalence of the population. So if you took a look at the 2010 census of the United States, the adult population is 245 million. And we know, based on data from severe obesity from the CDC, is around 8%, even higher in minority populations, close to 14% in African Americans, but 7%, 8% of the general adult population. And if you roughly estimate that of people who have BMI above 40, half of them may have an HI above 5, and that you could say that's a conservative estimation. That takes you to 9.4. So now you have 9.4 million people in the U.S. who are adults, who have BMI above 40 and have an AHI above 5. And if you say, well, 10 to 20% of them have OHS, and say you take the 10%, the lower end of that, these are the numbers you get. Close to 1 million people, or 1 out of 263 adults. Now, to put it in perspective, that compares, you can see here, obviously not as common as very common conditions like diabetes, asthma, COPD, but not as uncommon as you would think compared to other disease entities listed here. So the point here is that it's probably more prevalent than one sees or suspects in clinical practice, partly because we don't do systematic blood gases on these patients, and to some extent understandable, because first, it's not readily available in clinic or in the sleep labs, and patients and clinicians may be a little bit weary about sticking a needle into the radial artery. So, but again, studies that look at this more systematically is not as common as we think, as listed here on this slide. The prevalence tends to be high, particularly higher in hospitalized patients who are obese, or if you have more severe levels of obesity. So in terms of how these individuals present, a while back we tried to summarize the literature looking at what had been published up to that point. And in general, they don't present very young in life. Most of them present in 6th decade of life. Women present a little bit older than men, but women are quite well represented in OHS. They tend to be more obese than men. They tend to be older than men, to some extent reflecting the postmenopausal status. But many of the studies out there published about OHS, close to 40-50% of the patient population are women, compared to, for example, OSA studies where the proportion of men is substantially higher. And you can see the average BMIs. Again, in people, these are summary of data of people presenting in steady state, not hospitalized with acute and chronic hypercapnic respiratory failure. And you can see that the PCO2s on average are in the low 50s with some degree of hypoxemia. Interestingly, secondary erythrocytosis is not very common despite having significant hypoxemia. And I've always wondered whether that's due to some degree of chronic inflammation, on the other hand, suppressing the effect of hypoxemia in terms of the bone marrow effect. Dyspnea is quite common. The Medical Research Council dyspnea scale of 3 and 4, 4 is the highest, means that these people are quite symptomatic in terms of dyspnea. And in contrast to severe OSA, sleepiness, here measured by the Epworth Sleepiness Scale, is quite common in this patient population. And when you look at their polysomnography data, they tend, as I said earlier, severe OSA tends to be quite common. They may have mild restrictive defect. They have significant hypoxemia during polysomnography as well. So here I summarized 2 studies that are not recent, that we published a while back. The first one is, the top one is a study done in Spain, where they looked at all patients admitted with acute and chronic hypercapnic respiratory failure to the ICUs. And the majority were COPD patients, but 173 of them were patients with obesity and hypoventilation. And what's interesting is that 65% of these 173 people had prior ICU admissions, and only 9 of them were on treatment at home. The point here is that, unfortunately, many of these patients get diagnosed late, despite having multiple hospital admissions. Another study, the one on the bottom by Nobar, which was done in Denver, looked at patients hospitalized on general medicine wards and who had a BMI above 35. And so these are non-ICU patients. And only 13 of them, despite the fact that they were recognized by the research team and this information was passed along to the clinical team that, hey, your patient has OHS, only 13% of these patients were discharged on therapy. And they had much worse outcomes that I'll share with you in a second. The point here is that it is underdiagnosed and undertreated. And the other important thing is looking at misdiagnosis. This study from Paul Merrick's group when he was in, I think, West Virginia, They looked at ICU patients. Again, this is a retrospective study, and it looked like 8% of all ICU patients met criteria for OHS, and sadly, 3/4 of them were mislabeled as COPD or asthma, even though they were non-smokers, or later on when they got spirometry, they had no evidence of significant upper airway, of obstructive airways disease. And many of them were labeled as heart failure without any good evidence of heart failure. So, so that's misdiagnosing or mislabeling them is also not uncommon in clinical practice. So, two ways these patients can present in clinical practice. One is, sadly, the more common one, which is acute on chronic hypercapnic respiratory failure. These patients hit the ED, get transferred to the ICU, and unfortunately, as I showed earlier, many times get labeled as COPD exacerbation or something like that. The other way we can recognize these people is when we see them in clinic, or when you're reading a polysomnogram and you just see this atrocious hypoxemia during sleep that you don't normally see in patients with severe OSA, and you start wondering, why is this patient so hypoxemic, so profoundly hypoxemic? And you start looking for causes, be it heart failure, lung disease, and you don't find anything. And obviously that's when, you should start suspecting maybe something else is going on. So this brings us to when should you as a clinician suspect OHS? Again, in people of non-Asian descent, so African Americans, Latinos, people of European ancestry, it's not very common to see OHS with a BMI below 40. Again, I didn't say it's impossible, but it's uncommon. So when you have a severely obese patient who, you're seeing them in clinic and they've had, prior basic metabolic or comprehensive metabolic panels from venous blood, and you see that they have elevated serum bicarbonate levels, it's important to ask the question, why is it elevated? And it's also important to recognize that medications can lead to elevation of bicarb, particularly loop diuretics. The other thing that sometimes you notice is these patients are hypoxemic on room air. And I always tell people a patient who's resting on room air should not be hypoxemic, and OSA patients who are resting while awake do not develop hypoxemia. So if a patient has hypoxemia, you need to ask yourself, why? Why is that? So this is a study we did a while back looking at patients referred to us who were obese and had OSA. And you can see the sample size there. And there was nice dichotomy when we looked at bicarb below and above 27, roughly half in each group. You can see for those who had a serum bicarb from venous blood, that was, and this is total CO2, basically measured in most, laboratories. But again, this is venous blood. If it was less than 27, the chance of them having OHS was extremely low. So low bicarb is helpful to rule out, but high bicarb is a coin toss. You see 50%, so it's not good to rule in. And essentially, this is a busy slide, but I'll summarize by saying that in the ATS clinical practice guidelines that was published a couple of years ago, we summarized the literature, and in a nutshell, the conclusion was that a low bicarb is useful because it can help you rule out or decrease your clinical suspicion for OHS substantially, but a high bicarb is not diagnostic, and confirmatory tests are needed. Now, when you think about how these patients, many of them present with respiratory failure, acute on chronic respiratory failure, you can think about this, description of how we maintain homeostasis when it comes to breathing. Thinking about the two sides of the balance here, respiratory load and respiratory drive and strength. Now, clearly, as our body mass index goes up, as more tissue you have, be it adipose tissue or anything else, you produce more CO2 because those cells and that tissue is metabolically active. The great majority of people with morbid obesity do not retain CO2 because they augment ventilation. Again, those who develop OSA also have increased resistive load in terms of upper airway obstruction, particularly during sleep. But what really leads to OHS is for these individuals who have blunted respiratory drive at the central chemoreceptor sectors, because if the respiratory drive is not blunted, they compensate by augmenting ventilation to maintain homeostasis. And so if a patient is borderline OHS, you can imagine a scenario where something that increases respiratory load or decreases strength can easily tip him over the edge, and they get an acute on chronic hypercapnic respiratory failure, which makes them land in the emergency department. And that's when many times there's an opportunity for recognizing these patients and initiating therapy. In terms of pathophysiology, I wish it was a little bit more simpler, but it's a combination of things that lead to problems. And the most exciting area that I think, my good friend Jonathan John will cover in his talk tomorrow is this concept of leptin resistance. We think it's real, and, very nice data from, the Johns Hopkins group led by Seva Polotsky has shown in animal models in the murine model, how this leptin resistant phenomenon is real and how it can potentially be treated. So, but I think what leads to OHS in human beings is a combination of things. One for sure is leptin resistance, because as these individuals augment body mass by putting on more adipose tissue, they actually produce more leptin because adipose tissue can produce more leptin. So the question is, if leptin acts at the hypothalamic level to induce or increase ventilation to compensate for increased CO2 production based on that excess adipose tissue, why do these people then develop hypoventilation? And that's where the concept of leptin resistance comes in. In peripheral circulation, there's higher leptin, so the fat is producing more leptin, but it's not making it to the breathing centers in the brain in order to activate and lead to additional ventilation. So that's one concept. The other concept is, I think most of us as sleep specialists can understand why obstructive sleep apnea will lead to acute hypercapnia during sleep when you don't have opportunity to unload that CO2 that you accumulated during a long apnea. What is more difficult to kind of wrap your head around is why would then they develop CO2 retention during the daytime when they're not having obstructive apnea or obstructive hypopneas? In that model, there's some mathematical modeling from the former NYU group, David Rappaport's group, which are now they're at Mount Sinai, trying to explain this by explaining how the kidney may be involved in this sense. So when you experience acute CO2 retention during sleep, the next day, if you don't get rid of that extra bicarb that you accumulated as a compensation mechanism, then you may start at a new threshold in terms of some degree of metabolic alkalosis, which can in turn pull onto your ventilatory drive. And that cycle can get exacerbated. And again, this is the very nice study that I think Jonathan is going to talk about in more depth tomorrow, I hope. So I'm not going to belabor on it too much. But so this study was really a landmark study, and I was privileged enough to write an editorial on it together with Mary Ip of Hong Kong, because I think it brings a lot of value to the field, and many of us are very excited about this because it could become a therapeutic option for patients. I mean, we're very early in these stages, and obviously a lot of research needs to be done and prove this concept in humans at some point, but we're talking about several years down the road. But I think this is going to be very exciting to see if there's a way to deliver leptin and bypassing this blood-brain barrier resistance to leptin. If we can deliver it, for example, intranasally directly into the central nervous system to make it active. So again, very exciting work. Hopefully Jonathan will cover it in more depth tomorrow in his talk. So in terms of therapeutic approach, one question that comes up is, why should we even treat these patients? Well, I mean, this slide, it doesn't do justice to a lot of work that people have done, but suffice it to say, compared to obese patients who don't have hypoventilation, or to equally obese people who just have OSA without hypoventilation, these individuals die more. So it has a really high morbidity and mortality burden. And I think treatment can improve outcomes. This was a study done in Denver that shows that when patients were discharged from the hospital, without therapy, in the red curve, you can see that all-cause mortality was higher up to a year and a half after follow-up compared to people who had morbid obesity but were eukapnic, or no CO2 retention. None of them died in the hospital. During the hospital, they had more ICU transfers and intubations, but the mortality came later on. And here I tried to summarize data on mortality. You can see that if you look at in-hospital mortality, the study that I just showed you from Denver, the NOVAR study, that 0% death in the hospital. This study from Spain also had 0% death in the hospital. This study from Spain had 6% mortality. These were ICU admitted patients. And Paul Merrick's study also had 15% hospital mortality. When you look at longer-term mortality, so the NOVAR study that nobody died in the hospital, at 1.5 years, 23% died. And Carrillo's in Spain, 18% died at 1 year. And Paul Merrick's study that had 16% mortality in the hospital became 31% mortality at 3 years. Now, again, one of the problems with these three studies is that we don't know what percentage of these people were receiving therapy. And my suspicion is that very, very low percentage, or maybe none. Other studies in which people have been getting therapy, mortalities, you can see, are lower. Now, you might say, well, these numbers are not substantially lower, but look at the time frames. 7 years, 2 years, 5.5 years, roughly. So we think treatment does lead to lower mortality, although it's hard to justify a clinical trial where you randomize people to therapy or no therapy for a very, very long period of time. So this is somewhat based on observational data. And I think, unfortunately, they are, I think the slides that I had, the most recent slides that I had shared have not been uploaded. These are my older slides, but that's fine. I'm going to focus mostly on, I'm not going to talk too much about pharmacological therapy. Not that oxygen is a drug, but because there's not that much data on these approaches. I'm going to focus mostly on positive airway pressure therapy. So there are a variety of options out there. You know, you have CPAP and you have non-invasive ventilation. Within non-invasive ventilation, you have bilevel in spontaneous mode, bilevel with a backup rate, and you have more advanced forms of bilevel, which are volume targeted pressure support. And then on top of that, you have even more expensive devices that are considered like home mechanical ventilators, such as your Trilogies or your Astrals, depending if it's Respironics or ResMed, which are quite expensive. So in terms of short-term therapy, I can tell you that when you look at CPAP, CPAP titration failure is something that is a little bit difficult to define. Some people have tried to define it as persistent hypoxemia. And then the question is, what do you define as persistent hypoxemia? Like some studies have said below 80% for 10 continuous minutes, while on adequate CPAP pressure, inadequate CPAP pressure would mean the pressure that kind of resolves apneas and hypopneas and snoring, so on and so forth. So this study from Australia reported that 43% of patients had persistent hypoxemia despite being on adequate CPAP pressure. And you know, the counterpoint to that would be that 57%, 57% of people will have adequate CPAP titration. This small clinical trial from Australia randomized people to CPAP versus bilevel without a backup rate. And in general, there was no significant difference in terms of reduction on PCO2 after 2-3 months of therapy. And another study, a little bit larger study, also from Australia that was published in 2017, randomized patients to CPAP versus bilevel now with a backup rate. And at 3 months, again, there was no significant differences. And the primary outcome here in this study was also changing CO2 in the arterial blood. No significant differences between these two modalities. When you look at the more advanced bilevel modes, such as average volumetric pressure support, which is a volume-targeted pressure support mode in which the inspiratory pressure can adjust and based on the estimated exhaled tidal volume. If the tidal volume drops below a certain level, the inspiratory pressure can go up. So in this study from the UK, patients were randomized to average volumetric pressure support versus bilevel with the backup rate. And at 3 months of therapy, there was no differences in these outcomes listed here in terms of gas exchange, quality of life or sleepiness, so on and so forth. Importantly, what I want to share with you is that when you look at the breakdown of what the settings were, you can see that the delivered IPAP between the two groups were not that different. The EPAPs were not that different. Leak or percentage of breaths that were delivered by the device versus patient-triggered breaths were not that different. Adherence was not that different. And the change in CO2 was not that different. Now, in this study, the people were randomized to bilevel PAP in this group. They had a very aggressive and nice titration protocol, so that with the idea of giving them really, really nice and juicy pressure support. Look at the pressure support here. That's 13 centimeters of water worth of pressure support, the delta between IPAP and EPAP. So if you, I think the take-home message is that if you do a very aggressive and nice bilevel PAP titration with the backup rate, then you probably will be equal to an AVAX. That's, I think, the take-home message. Here's a more recent study from a group in France, Jean-Louis Pepin and Renaud Tamissier's group, and similar idea. Here they're using average volumetric pressure support with the auto EPAP mode, kind of like your auto CPAP. So you don't have a fixed expiratory pressure, but it can adjust based on obstructive events in the upper airway versus bilevel PAP with the backup rate. Again, you can notice the mean IPAPs, the mean EPAPs, the backup rates were very similar, and not surprisingly, the outcomes in terms of CO2 levels were not that different either. Again, pointing to the fact that if you do a nice titration, and you can see the average difference between IPAP and EPAP here is also around 11 centimeters of water. So if you have decent amount of pressure support, there's probably not that much difference between the two modalities. So this brings us to the Pickwick study. In this study, I'm going to focus mostly on this part of the study and mostly in this part of it. So here the patients were classified, patients with OHS were classified into two groups. Do you have severe OSA or you don't? You can see this is where the number came from that I told you, 70% of patients with OHS have severe OSA. So if you had severe OSA, there was a 2-month study where you would get randomized to 3 groups. One was essentially nothing. And then this group, in order to kind of satisfy the ethical boards and the IRBs, were re-randomized after 2 months. And this group was followed for 3 years, minimum of 3 years. And this group, in patients who did not have severe OSA, they were randomized to either NIV or lifestyle and followed for 3 years. So this is the group that was severe OSA, 3 years of follow-up, minimum of 3 years. You can see that they were randomized to CPAP, and this was the average CPAP, and the average use was around 6 hours per night. Or they were randomized to volume-targeted pressure support, kind of like your AVAPs, if you think about it, with the average pressures being around 20/8. So roughly 12 of pressure support with a backup rate of 14, similar adherence, 6 hours per night roughly. Outcome of interest was hospital days, meaning how many days patients spend in the hospital. You can see that there was no significant difference between that. Also looking at incident cardiovascular events, 15% versus 17%, and mortality. None of these reached statistical significance. Looking at Long-term survival, you can see the survival curves. No difference between CPAP and volume targeted pressure support, which is the NIV mode here. In terms of mortality, the causes of mortality, you can see that of the 16 people who died in the CPAP arm, the majority were cardiovascular reasons. In the NIV was the same thing. So still a high burden of cardiovascular problems in this patient population, which is not surprising and to some extent maybe similar to the OSA literature, suggesting that, you know, the approach to these patients cannot just be, let's just give them positive airway pressure therapy. Maybe they need a comprehensive approach in terms of weight loss, increased physical activity to really modify cardiovascular risk. Looking at changes in PCO2 longitudinally, both groups had a significant drop in CO2, but intergroup, meaning the differences between CPAP and NIV, was not significant. So both groups, you can see nicely, CO2s went down and remained down over time. Here is changes in oxygen in the arterial blood. You can see that as ventilation got better, oxygenation got better too. No difference between the two groups, but significant in both groups. So intra-group, it was significant. Intergroup, no difference between them. Here is percent going from significant dyspnea to no dyspnea. In the NIV group, dyspnea dropped from 63% at the beginning in yellow down to 27%. In the other group, dropped from 54 to 33. Both of them were a significant drop, but no difference between them. Need for daytime supplemental oxygen. This is one of the points that patients care about. Do I need to remain on oxygen during the daytime? And the point here is that over time, at baseline, 27% in the CPAP group and 22% in the NIV group needed to be on oxygen during the daytime, during wakefulness. But over time, you can see that this number dropped to 13% and 11% respectively, and there was no difference between them. So both groups dropped significantly, but no difference between them. Here's your Epworth sleepiness scale. So you can see that for NIV in blue, it dropped from a baseline of around close to 12 to close to 6. So 6-point drop. CPAP, very similar as well. So significant drop in both groups, but no difference between them. And a lot of this boils down to adherence. Here, several years ago, we showed that in patients with OHS who use their PAP device more than 4.5 hours a day versus less than 4.5 hours a day, the improvement in gas exchange in terms of CO2 levels and PO2 levels were substantially higher in people who were adherent than non-adherent. And this also summarizes adherence in the Pickwick study. So whether you got NIV or CPAP in terms of randomization, as long as you were adherent to both of them, there was no difference in mortality. If you were non-adherent to CPAP or NIV, you had worse outcomes in both groups. Which brings us to how does adherence to CPAP or NIV compare to CPAP adherence in OSA patients? So this is a paper that I wrote with 2 of my former fellows. And what we did was to look at the clinical trials of OHS and look at the adherence in the CPAP arms and in the NIV arms. And here's a summary. You can see on average, no difference between them. And on average, you're using it close to 6 hours per night. Then we looked at clinical trials of CPAP in blue and red or pink. And so these are non-OHS, these two groups. And then these were studies where people were randomized, OSA patients were randomized to usual care versus telemedicine to enhance adherence, or usual care versus behavioral interventions aiming at improving CPAP adherence. And you can see that in both telemedicine approaches and behavioral interventions to improve adherence in OSA, adherence gets better. But they don't reach OHS, which begs, and in these OHS trials, there was no intervention to improve adherence compared to these other trials of OSA, which begs the question, why do these people use their CPAP or NIV much more. And I think it boils down to they probably feel they derive more benefit, they're more symptomatic compared to OSA patients. Now, the other concept I want to touch on is, what do we do when we have these patients in the sleep lab and we put them on CPAP and all hell breaks loose? You know, they have significant hypoxemia, persistent hypoxemia. In some labs where they measure transcutaneous CO2, they have persistently elevated transcutaneous CO2 despite cranking up CPAP to like 17, 18, 19, 20 centimeters of water. And you see that OSA is almost gone. Hypopneas, apneas are gone, but hypoxemia persists, particularly in REM, for example. What do we do with these people? Technically, you could label them as CPAP titration failure because they had significant hypoxemia. What I want to call your attention to is these 3 patients. Each line is 1 patient. And each patient underwent 3 studies: a baseline polysomnogram, CPAP titration, which was done usually in a few days, and 6 weeks after CPAP therapy. And in this clinical trial, even once you were randomized to CPAP, even if your CPAP titration looked terrible, too bad. You were randomized to CPAP, you were on CPAP. So CPAP titration failure, but you're stuck with it. And you can see that all 3 of them on this night, that significant hypoxemia in terms of T90 and T80, right? And when they came for CPAP titration, numbers got better, but like this individual had 30% below 80%, 30% of the sleep time, or 10% of the sleep time. But nonetheless, they were discharged on CPAP, and most of them were getting CPAPs anywhere between 17 to 20 centimeters of water. They were quite adherent, with adherence of around 6 to 7 hours a night. And 6 weeks later, they came back for another PSG on room air with just on CPAP. And you can see that all that hypoxemia that defined them as CPAP titration failure was gone. The same thing happened in the Pickwick trial. In the Pickwick trial, when you were randomized to CPAP, the randomization happened before the polysomnogram. So if you were randomized to CPAP and you had a terrible CPAP titration night, tough luck. You were randomized to CPAP and you got it. And you can see that after 36 months of follow-up, I showed you all the data: Epworth, dyspnea, need for daytime oxygen, PaCO2s, PO2s, mortality, hospitalizations. Nothing mattered. No difference between them. So CPAP titration failure is not necessarily equal to CPAP treatment failure down the road. Just that's one concept that I want to try to kind of convey here. Other things that we learned from Pickwick, of course, this is not rocket science. CPAP is cheaper. That's a no-brainer. And in terms of pulmonary hypertension, we noticed that both treatments, CPAP and NIV, led to improvements, with a caveat that these were done by echocardiography and not right heart catheterization. In fact, when you categorize the patients, so when these patients with OHS presented to the study, only 10% knew that they had pulmonary hypertension or they had been diagnosed with pulmonary hypertension. But when echocardiography was done at baseline, 50% of them, half of them, had evidence of pulmonary hypertension, defined as PA systolic pressure measured by echo above 40. So if you look at the cohort, the half of the patients who had evidence of pulmonary hypertension at baseline, the drop in PCO2, regardless of whether you receive CPAP or NIV, was around 8 to 10 millimeters of mercury in follow-up echocardiograms. Of course, if you didn't have elevated pulmonary artery pressures, there's like a floor effect. You can't make it better, right? So that's one of the things we noticed in the study. Again, with the caveat that we don't have right heart catheterization, which I would argue is difficult to do because you're doing multiple measurements and subjecting so many patients, like 200 people, to 3 or 4 right heart cath will be a challenge for a clinical trial. Not impossible, but a challenge. So when should NIV be considered? Now, so far, I've told you that CPAP is pretty much as good as non-invasive ventilation in form of bilevel or volume-targeted pressure support. Well, I would say, obviously, all these studies that show that they're equal are done in patients who are really in steady-state ambulatory patients. So patients who get admitted to the hospital with acute on chronic hypercapnic respiratory failure is a different ballgame. many of these studies that showed that there was no difference between CPAP and NIV, also on average, the CO2 was hovering between, low 50s. So what do you do with a patient who has like a body mass index of 60 and has a PCO2 in steady state, not an acute decompensation, but in steady state, has a balanced pH, like 7.35, and a CO2 of 60? Would CPAP be the same as NIV? We don't know, because most of the patients enrolled in clinical trials didn't meet that criteria. So I think future studies will give us better sense of what patients would benefit from NIV more than CPAP. But in the clinical practice guidelines, what we said is that, we should consider the concept of CPAP failure, not titration failure, but you put them on CPAP, you demonstrate that they're using it, they're adherent to therapy based on objective adherence data, and they come and see you several weeks or several months down the road, and they remain symptomatic, or they remain significantly hypercapnic. Maybe those individuals would benefit from more aggressive form of positive airway pressure therapy in form of some modality of NIV, be it BiPAP with a backup rate or without a backup rate, or volume targeted pressure support. So those are kind of the ideas we talked about in the clinical practice guideline. Now, another topic we approached in the clinical practice guideline was what to do with people who are hospitalized with acute on chronic hypercapnic respiratory failure, suspected to be due to OHS and not COPD, and is now getting time to discharge. They survived hospitalization, and now they're getting discharged. Many places don't run sleep studies while the patient is hospitalized. They can't bring him to the sleep lab. They want to do it as an outpatient. They have a wait time. Sleep clinics are busy. Suffice it to say, it's not easy. So what do we do? And there's no clinical trials that have actually looked at this issue. So what we did is try to obtain data from investigators who had published 9 clinical studies, observational studies, but no clinical trials, where we could do a composite of the data and try to understand what happened to these patients. So you can see in general, close to 1,100 and something patients who had been discharged from 9 different clinical studies. Again, none of them were RCTs. These were just observational studies. And 10% of them were discharged on no PAP. 1,000 of them were discharged on PAP. 92% of these PAPs were NIV. None of these studies are from the United States. They're all European, Australian. And what you can see is that there's a lot of bias here, because we don't know if this group that did not get discharged with therapy had other things that may have led to worse outcomes. With that said, 17% of people died here at 3 months. 2% of people died here at 3 months. And if you look at 6 months, it is 23% versus 5%. So significantly less mortality, but with significant bias. So the fact is, and that's why in the clinical practice guideline, we said that this evidence is compelling, but it's very low level of evidence. And we need more research in this area, which brings us to one of the studies that we're hoping to start soon, a multi-center clinical trial, where patients who survive hospitalization with an acute on chronic hypercapnic respiratory failure get randomized to either lifestyle modification versus lifestyle modifications and kind of like a bi-level with a backup rate device on which they get discharged. And they come in 3 months to the sleep lab. And the reason we said 3 months is because we said most sleep labs have a wait times of 2-3 months. So we think, from the ethical standpoint and from IRB standpoints, most people would suggest that that's fine. And I just showed you some slides that some, observational data suggests that at 3 months they may have worse outcomes. So this will be an interesting study to do, which hasn't started yet, but we're in the process of getting it up and running. Let me skip this slide. And then the question that comes up is it safe to switch people from NIV to CPAP? Let's say you discharge a patient on NIV and, you want to see them in clinic and they're fine, and do you need to stay on NIV or do you switch them on CPAP? And this study was done looking at that question, and, upshot of it is that, a good chunk of patients, 71% of them, were able to be switched to CPAP without any worsening of parameters measured. What's interesting is that many patients actually prefer this sort of, so people who are on NIV, mostly either bi-level with backup rate or volume assured pressure support, when they were switched to CPAP, many of them actually preferred CPAP, which brings up the issue of maybe with more advanced modalities, maybe there was more desynchrony, particularly when the device is trying to give you a backup rate and the device is not well set up, so there may be some patient-ventilator desynchrony that might create or add to the discomfort level. Anyway, just food for thought. In terms of other therapies, oxygen, in my opinion, should not be used as a single therapy. In some patients, oxygen can worsen ventilation, particularly when the oxygen is given at higher concentrations. Bariatric surgery, let me skip that slide. You would think there'll be tons of data on this, but when we try to summarize it for the clinical practice guidelines, we summarized it very simply like this. The data suggests that for patients' OHS to resolve, essentially for hypercapnia and hypoventilation to go away, there needs to be a substantial amount of weight loss. As you can see here, 25 to 30%. And the fact remains that it's very rare a patient can do that on their own. Even studies where patients get enrolled in intensive lifestyle modification, in general, the weight loss tends to be, anywhere between 10 to 15 kilograms, and is not sustained. So that's why bariatric surgery has an important role, although many of these patients don't like to get bariatric surgery, or many times you get into this cycle that the bariatric surgeon says, I don't want to do bariatric surgery until their OHS gets under control, which could be reasonable, but again, they get into this cycle. Medroxyprogesterone, as I said earlier, I'm not going to talk about it too much because we don't have enough evidence, but I guess those slides are there for yourself to look at. Same goes with acetazolamide. In terms of tracheostomy, this data now more than 20 years ago actually comes from Hopkins Group, and is a retrospective study showing that small sample here, 13 patients, many of them who had evidence of hypoventilation. You can see that once they got trached, their CO2s, many of them got below 45. The important thing here is to recognize that in a subpopulation of patients, in a smaller cohort of patients who their hypoventilation is not necessarily all OSA driven and is perhaps weight driven, you may have trach, but they may still remain hypercapnic and even severely hypercapnic. And some of these patients may end up needing mechanical ventilation through a trach. So my opinion is that be careful and not promise to the patient that if they get trached, they may not need ventilation because OHS will get resolved, because sometimes it doesn't get resolved. So to conclude, I had some few additional slides in terms of the advocacy work that we're doing, trying to convince Medicare. I shared those slides, but I think they uploaded the old version of my talk. Regardless, we can talk about it during Q&A if there's time. But hopefully I've convinced you that OHS is prevalent, and particularly in people who have severe obesity, and is frequently unrecognized or undertreated. And again, there's not a lot of RCTs out there, but I think data from observational studies and small RCTs suggest that they do get a lot of benefit from therapy, positive air pressure therapy. But at the end of the day, if we want to really make a dent in trying to improve their cardiovascular and mortality even further, we cannot just focus on PAP therapy. It has to be more comprehensive in terms of weight loss, physical activity, and those kind of things. So with that, I'll stop there, and and again, I thank you for the attention, and happy to take any questions. Thank you so much.
Thank you for a wonderful presentation. I just want to say that was extremely rich. I think some of the take-home points for me from this was not just in being able to recognize the obesity hypoventilation syndrome, understanding that as a diagnosis of exclusion, so thinking in terms of the differential diagnosis of other causes of hypoventilation, but I think you've made some really key points that I would suggest I think of in terms of analogies. And I would say that you brought up, and the thought that comes to mind, and it reminds me of a conversation we had a couple of years ago with Chirag Javahari with complex sleep apnea. And you know acutely in the lab what you see that night and what would be considered appropriate actions with what would be reasonable indications might lead you down one therapeutic pathway, which was, hey, do we take that person with complex events and now put them on adaptive servo ventilation? Or do we take Dr. Javahari's approach, which is give them the machine, hold their hand, talk to them for 6 weeks and say, I promise you, I think we've got an 80% chance this is going to get better. So I think you really drove that home here. I'd like to share a scenario with you because I know we have only a few minutes left. Because I practice in a VA and because I've had very limited space available in the lab, I have generally gone to auto titration in the event that I was, say, unable to do a home sleep test and I sent them to the lab. So, a lot of these folks I've seen that they may have significant hypoxemia. And so what I've noticed for myself is sometimes I'll have these patients where AHI is corrected. I was concerned about nocturnal hypoxemia in these patients. I put a pulse oximeter on them at night. I get the download specifically looking at the specific night when they wore the pulse oximeter, and we'll compare the pulse ox tracing and try to put it in time with the detailed data from the smart card download. And, I sometimes still see residual hypoxemia, and because I'm not monitoring CO2, my first thought is, am I dealing with a hypoventilator here? And should I do some additional work? I think part of what I find that I struggle with is to say, look, you've made some very good points to say, I don't know that I can show outcome data to say that BPAP-ST or AVAPS is better than CPAP, at least by the data that you presented, the data I'm familiar with. I struggle to make such an argument. I've asked myself, is it appropriate and reasonable to put these patients on oxygen? I can say, hey, at least they do meet Medicare criteria. I'd be curious to hear your thoughts and how you might approach that situation.
Yeah, so you're not alone in that dilemma because we also deal with the same problem. And, you run these studies with oximeter and you notice that despite having their PAP on, they have hypoxemia. And I'll put a caveat here that in the Pickwick trial, one of the downsides is that we didn't have CO2 monitoring during sleep. So that's one of the downsides we have. And we didn't bring him back down the road for multiple studies to see what happens at night. So those are all the things we don't know. But my inclination is that if the patient has, significant hypoxemia while wearing PAP, and this has been on it for a while now, not just a few days, but at least for a few weeks, and they've demonstrated adherence, and they have, and then the debate is how do you define significant hypoxemia? But let's say you define it in your own mind and you're convinced. Usually, I like to bring those patients back and study them on transcutaneous CO2 monitoring to convince myself that they are retaining CO2, and if I try them on bi-level, I can make them better. That's in a situation where the patient has no obvious reason, because occasionally I have patients with PH, pulmonary hypertension, or they have also concomitant COPD or overlap, where there may be a reason already there for hypoxemia. And in those situations, I might sometimes argue maybe they just need a little bit of supplemental oxygen added to their CPAP. So yeah, it gets a little tricky. But yeah, occasionally I face a situation like you do, and I say, well, I'll just bring them back to the lab.
Okay, and then I was asked a question here. Can you comment on the Medicare criteria demonstrating desaturations for OHS patients on 2 liters or their usual FiO2 in the hospital setting, in addition to hypercapnia to qualify for CPAP versus non-invasive ventilation?
Yeah, so that's some of the slides that are missing when I send my new talk, which was not uploaded, which is fine, because there's an advocacy group trying to convince Medicare that the current criteria for RAD devices or respiratory assist devices, meaning devices with a backup rate, is archaic, and it was written in 1998. And there's been a lot of improvement in technology and delivery of care that we need to kind of update it. So I'll say that those rules that you just mentioned are archaic, are outdated, and they're ridiculous and worthless. And we all have to stick to them because we have no choice. But one of the things that we're doing in terms of advocacy is that we're writing new guidelines, not guidelines, but recommendations for the Center for Medicare and Medicaid Services in terms of hypoventilation syndromes, hypercapnic COPD, neuromuscular thoracic restrictive defect, central sleep apnea, all of these categories. And there's a group of technical expert panel group that Peter Gay from Mayo and Bob Owens from UCSC are leading. And we have different groups. I lead the hypoventilation group, and Lisa Wolf from Northwestern leads the neuromuscular group, and other people lead other groups, like Sushil Patel is leading the central sleep apnea group together with, for the OSA group, together with Nancy Collop. The point here is that we're trying to give recommendations that are sensible, help our patients, reduce the level of pain for clinicians, and come up with a system where the right patient can get the right device at the right time without having to jump through these ridiculous rules that Medicare has. So I would say that the rules are terrible. They should not exist. We're advocating for them to go away, but our recommendations to Medicare, unfortunately, are non-binding. Medicare could, what we're telling Medicare is the reason that prescribers and the number of home mechanical ventilation, like Trilogies and Astral, are going up, and the Office of Inspector General is putting a red flag on them, is not because doctors are trying to commit fraud. It's because doctors want to do the best for their patients. And if you create such ridiculous rules that are archaic and outdated, the doctors will find a way to help their patients. So you need to update your rules so I can prescribe a bi-level with a backup rate that is much cheaper than a Trilogy device. That's the angle we're taking. So we're trying to get rid of these rules of spirometry, of continuous oximetry, of you have to fail bi-level without a backup rate to qualify for bi-level with a backup rate. We're trying to get, our suggestions to Medicare is to get rid of these rules and come up with new criteria. As I said, these recommendations are going to go, and then if Medicare accepts them, eventually it's going to lead to national coverage determination changes that will trickle down to all the DMEs. That's the advocacy we're trying to do. I can't make any promises, but we're trying, because we all recognize as clinicians in the trenches practicing medicine, we know the pain. And that's one of the things that we're trying to advocate for to change.
Dr. Mokhlesi, I could keep you here another half hour, but I have other speakers in the wings, and all I can say is it is a pleasure to have you here. I look forward to another conversation with you, and thank you.
Thank you so much. I appreciate the invitation.
Bye-bye.